Podcast. I'm here with my partner, Yader Sandoval. Yader, good morning. And we're talking about complications and how CT can help us prevent and treat complications. So Yader, CT is growing in use. We're seeing more and more of it happening every day. And we've both of us informally seen it be very useful in having less complications. And sometimes we use it after a complication. But tell me a little bit, are there some cases that stand in mind that CT really help you prevent or potentially know before that the complication was going to happen?
I think CT may play a role, right? And we can go maybe point by point, but the first one that comes to mind, and I think we've alluded to this before in some previous episodes, is that if the CT shows some high-risk anatomy at the upfront, aortic oscillation, calcific disease, CTO, something that it's already a high-risk phenotype, I think even before we talk about the technical issues, you can already talk to the patient and say, hey, this is a procedure that is going to be at a higher risk for complications than a traditional non-calcified type A lesion. I don't know whether you incorporate CT for the consent and shared decision making at the upfront, but I actually think this is an added value. I think many times we use the generic, this is a less than 1 or 2% risk for complications, but CT could be incorporated to provide a more personalized risk of complications.
Absolutely. We can see things that typically don't become evident until after you're in doing the angiogram, doing intravascular imaging, and now we can have them even before we start doing the procedure itself. And I agree with you, things like calcification, especially for CTOs, which we talked about, having a long occlusion length, having tortuosity, many things we can see before can help us understand the risks. But also, you can help prevent, I think, complications, because the complications sometimes arise from either undersizing or oversizing stents or balloons, and that can lead to rupture. Especially the oversizing part can be an issue, and sometimes we can overdo it, especially in larger vessels. I don't know what your experience has been in this, but CT, which is actually conservative, might give us a better way to prevent complications like this.
Since you're talking about lesion preparation itself and balloons and vessel size, again, I think historically, if people are not using intravascular imaging, people will look at an angiogram and guess some sort of balloon, right? With CT, I think we've addressed this before. Usually the CT will be acquired with nitrates, properly dilated vessel. I still think, at least in our experience, I know people will debate about this, when you compared an EEL-based measurement, external elastic laminar from OCT or from IVUS against, let's say, luminal sizes from CT, the CT will underestimate vessel size. But my point is, in my view, actually that errs in safety, right? Because you're not going to come with an oversized 3.5 balloon if the CT is telling you, is, let's say, 2.7 vessel. You can safely come with a 2.5 NC, high pressure. So, that's what I usually do in that sort of setting.
Also, it's much more sensitive for calcium, which predisposes you both to dissections as well as perforation. So we're kind of prepared to be more conservative in those cases and know that there is maybe a high risk of things going south, so we can mentally be prepared and also have the equipment ready just in case something like this happens.
Emmanouil, if I can jump in, because you brought this up when you were talking about CTOs, and I brought this issue about the shared decision making and your risk of complications. But maybe remind me, for CT, we have a lot of scores that have been validated for CTO, I guess for CTO complexity, like JCTO from CT. But I guess we can use all the CT scores that have been validated for CTO also to inform the risk of complications, right?
We can. Now, as you said, the CTO scores on CT, at least for now, they're validated for success, not for complications. The complication scores, there is essentially the main one is from Progress CTO, and that's not a CT, it's a clinical score, an angiographic score. Having said that, there is a score for bifurcation PCI that can predict the likelihood of losing the side branch. And that's based on the CT image, the plaque on the main vessel, if there is lesion or calcium on the origin of the side branch, the size of the side branch relative to the main vessel. So there is a nice score, 0 to 4, that with higher scores correlating with higher risk of occlusion. So that is something very specific that we can do using CT to predict what is the chance of losing the side branch and being extra careful to protect it before we get to that point.
Perfect. So I think that touches into one of the different themes, I think, of complication prevention or management or preparedness, how we want to refer to this, you have using CT, which is this issue of, I guess, bifurcations, right? So I think you're hitting the nail. There's a CT score for bifurcations. And I think for CT specifically, I think this is changing from the traditional CT bifurcation score that you could look at a lot of the traditional CT metrics to even some more modern assessments that we talked about previously, such as like these issues of myocardial mass, a side branch protection, how much myocardium is at risk from that. How do you see some of these tools evolving in complication prevention and management?
Great point. And the myocardial mass is something we'll be talking forever. Now it's finally becoming clinically available, which would help, I think, with adoption. And sometimes things are obvious. You have this huge diagonal that is the same size as the LED. Well, great, it's significant. But sometimes it can be more subtle. And for example, septals, which we don't think much of, sometimes can be supplying 10 or 12 or 15% of the myocardium. And we often are fairly not very careful about protecting them. So that can help us be much more accurate about which are the big branches that are more important to be predicted. So I think this exciting development and having this clinically available will help with planning bifurcation PCI much better. But having said that, also the CT can be very useful if, knock on wood, you have a complication. And what comes to mind immediately is this loculated effusions in patients with bypass. This is something the echo can sometimes miss, and the CT is the gold standard. Granted, this is not for planning, but this is after. But this also can be the golden standard for determining if something has gone wrong and how to fix it.
You're thinking now about post-procedural CT. Is that what you're thinking about? If you have like somebody that had an infusion and you want to assess that after the procedure,
Exactly. So the classic way we think of CT for planning is the pre-procedural, understand the PCI, the complexity, and everything else. But CT doesn't end there. And when there's a complication, especially again in bypass patients in whom you don't often see the free-floating effusions if you have a perforation, CT can really understand if there's a problem, where is the problem, and can sometimes help guide drainage, because you cannot drain it often with pericardiocentesis as we do the bedside. You may have to go with CT-guided aspiration of the fluid.
You raise a really provocative point there. I think when we said, hey, let's talk about the emergent role of using CT for, and its relationship to complication, prevention, algorithms and whatnot. I was really thinking about particularly the pre-procedural CT, but now that you're talking about the post-procedural CT, I think there might be some opportunities that we're thinking. You're talking about effusion. The other one that, as you brought this up, that comes to mind is, we're entering this new phase of modern scanners, photon-counting scanners, ability to see stents better, right? So I think something, for example, that will be very interesting how this evolves is, a stent under expansion, right? If you have now a way higher quality T and you can better assess stents, there will be other mechanical issues that, procedural complications or not necessarily, I guess, complications, but I guess you could say, signs of stent failure that you can find from the CT, right?
Yeah, absolutely. And you may wonder, are you going to bring those patients back for another procedure, which can happen if it's extreme under expansion and you're concerned for stent thrombosis. But even if you don't do that, if you understand that there is standard expansion, you will do something else. For example, extend your duration of DAPT or be more aggressive with your more advanced P2Y12 inhibitors so that you minimize the risk of stent thrombosis. So this is something that you don't necessarily see. And by angiogram, you don't, unless you do intravascular imaging. And CT can be very nice in detecting and help us appreciate and take action for it.
I don't know that yet we have any robust data to be talking about with a high level of confidence, because I think we're learning about it. There's some of the new scanners are just coming about. But again, thinking about photon counting scanners and how they promise that we may be able to look at stents, with improved visualization or resolution. You really, you're an expert. You tell me what you think, but I can think right now we can look at under expansion. Maybe and we see stent fractures. What if the stent is hanging out in the aorta, an aortal lesion, and it's hanging out, 5, 6, 10 millimeters? I think we're really going to be able to understand way better prior to the procedure all these potential stent mechanical problems that, if you understand it beforehand, could potentially really help you treat that stent failure complication.
Absolutely, and the same applies to some more rare cases, but they happen when you fracture your wire and you're not sure how far the wire is going. CT can really show you this is where the wire is, it's sticking out in the aorta, how long it's protruding into the aorta, can really provide you information of what is going on. And these wires can sometimes be very difficult to see. And regarding the stent you mentioned, there are some cases in which people may have to go in and snare those stents that's sticking out too much into the aorta. There have even been cases where the stent is interacting with the aortic valve and causing perforation of the aortic valve and severe AI. Not very common, but it has been reported. So being able to understand better how is the anatomy, how is the stent into the aorta, how much is wires in the aorta, can really help you decide if you need to do any more steps and what those steps might need to be.
So the other thing that we briefly touched on, but I think it's worth just pausing, and I know we've sort of like talked a little bit about it in a couple of episodes before, is the issue of perforation, right? And perforations, in my mind, come a lot related to calcium and whether one does not understand the phenotype of calcium well, and either you don't prepare it well, or let's say you come with, as you said, an oversized balloon. So how do you see calcium from CT and complication prevention connected, Manos? How do you what are the opportunities for us to reduce the risk of complications, specifically perforation, when we think about calcium in the cath lab?
Absolutely. There is, first of all, if there's calcium, the issue of perforation goes up. That's well established, we know it and everything else. But there are also some patterns of calcium that are more concerning than others. For example, if you have what's called a C-cut, it's calcium like a C, and there is a small portion of the wall of the vessel that doesn't have calcium. This eccentric calcium, this is a well-known correlation with perforation. Because what happens is, when you inflate the balloon cannot expand on the C area, so that ending, that open spot is where the balloon is going to go. And this is how perforations can happen. And this is why in this eccentric calcium, balloon inflations, aggressive balloon inflations should be avoided. And advanced calcium modifications, IVL, atherectomy, etc., can be very important to prevent this risk of perforation. Also, if you have, for example, trying to do reentry in a CTO and you have a lot of calcium, and the calcium is circumferential, that's going to be very hard. And you may not be able to do so, and you must find a zone, an area where there is less calcium that you can get through, because this very dense circumferential calcium can be very difficult to get through if you go into the extra plug space. So yes, CT can be very useful. You can know exactly what you're dealing with before you go in. And not only you try to prevent it by being more conservative or using more advanced techniques, but also you may be more ready to deal with this. And I don't know about you, do you get the pericardiocentesis kit in the room in those cases, or get the cover stents close by? How do you deal when you have cases that look highly complex and highly risky on CT?
It's an excellent observation, and again, these are topics that I think the message, it's important to continue to emphasize it to our colleagues. But I think you say this issue of preparedness, right? Having the pericardiocentesis kit or whatnot. To me, this comes to the beginning, right? If you're seeing features of disease severity that are of this concern in the CT, first and foremost, this is something that you want to do at your mothership, right? Where you have all the necessary tools, surgical backup, whatnot. God forbid you saw these high-risk features and you're doing this case at a place that you may not have the necessary equipment to tackle this. So I think this already talks about different elements of complication management preparedness, right? You want to do this, again, you could be in a place without surgical backup or even a complication kit to deal with this. So I think that's an important element. The other issue, going back to this issue of calcium, comes to this issue of preparedness, and a lot of this, I feel sometimes they special dissections, vessel perforations. You're bringing a compliant or a non-compliant balloon and blowing it up, and now you dissected the vessel or whatnot, right? Cause ischemia. Now you're going to spiraling into complications, and this happens, right? Sometimes one complication begets another complications. So if you know at the upfront this is circumferential calcium lung, it's a problem, I think you go ahead and you are proactive about treating this, right? Whether you say, I'm going to do, whatever it is you do, lithotripsy, atherectomy, but you're going to be proactive about this. And the issue from CT is that you can know, of course, and again, I don't want to shift this to a whole calcium topic because we could talk about this forever, but you're going to know the calcium length. You're going to know whether it's circumferential or not. Is the calcium close to a bifurcation? So you really can know how to tackle it. And I do think that a lot of potential complications relating to lesion preparation are because sometimes we are treating it just with the wrong tool, right? And if you know beforehand the phenotype of this, you're going to just treat it very differently, whether that's with IVL or atherectomy. Just to link, because we did talk already about myocardial mass and its bifurcations and calcium. I do think there is one particular phenotype of disease that it's both together, right? That it's calcium involved in particularly the main vessel where a side branch comes near that calcific segment. And I think we're increasingly learning that if there's calcium contralateral to the origin of that side branch, and let's say you think you prepared that, but you did not image, there's still some calcium there, the stent can go ahead and actually expand towards the side branch and jail that. So I think we're learning there's a number of ways to potentially be very proactive about these issues and prevent complications.
Absolutely. And there's more to learn as we're increasingly using CT. I think we're going to understand much better how to better use it to prevent and treat complications.
What are the final messages that you would share with our colleagues about the emerging opportunities for CT for complications?
I think it was a great conversation. For me, the key things are CT can help you understand key anatomic factors that are correlated with complications. Calcium is one of them. The morphology of bifurcations. You can also look at access. We can also see at the length and a bunch of characteristics for the CTO. Also, as you mentioned, you might be able to use less contrast during the procedure. Granted that CT itself requires some contrast, but during the procedure you might use less contrast and less radiation during the procedure because you already know what you're dealing with. And also it can be used after the procedure if there is a complication like loculated effusion or other issues, and then be able to understand better what is the problem and how it can be treated. We're going to learn much more about this as time goes by, but I think already it has a solid role and likely will be expanding over time.
This was a great episode. Always enjoy these conversations with you, Manos, and continuing to chat about all these opportunities that are now emerging with the use of CT for pre-procedural planning. But as this conversation alluded to, maybe even some novel opportunities even to post-procedural assessment. As we close the episode, thank you to all of our listeners for joining us for the Coronary Corner Podcast by SYSTOLE. For those of you that may be interested in learning, getting more hands-on experience, we would like to invite you. We're actually doing a workshop March 26, 27 in New Orleans with some hands-on training. I think people have been hearing from us this message about how to use CT, but I think a lot of people are interested in how to put their hands on and learning this buttonology and clicking. So please join us. Manos, any comments regarding some of these educational opportunities?
Absolutely. There's the best way to learn is to do, and this is a great way to get introduced. You get to hands-on use some of the leading platforms currently. So when you go back home, you can immediately get to work and have less barriers in how to use the CT. So thanks again. Looking forward to seeing you in New Orleans in the next podcast.